I have a fair bit of things to cover. I'll try and expand on what we talked about yesterday in just the basic session on ECMO. So just going to move forward. So these are some of the things that I'm going to try and cover in the allotted 15 minutes. So as we highlighted yesterday, I don't really need to spend any time on this. The principle of ECLS or ECMO is to support the delivery of oxygen to all cellular tissues and organ systems to maintain them in a state of health and enable time for their recovery from their primary, secondary, and tertiary disease states. That's the key principle. So it's not a treatment, but it is a support mechanism. And I already talked about this as well yesterday, but quickly, the neonatal ECMO has come and played a huge role because the first successful case was in 1975 when Bob Bartlett, who is the father of ECMO, was in Davis, California. And since then, there has been a huge explosion. This again talks about this, and again, I just want to highlight this once again, is that people may be talking about other kinds of ventilation strategies which are lung protective and so on, saying that these newer modalities are not going to be coming or need to be there. But there is definitely the need, as is seen by the evolving number of centers and the increasing number of ECMO cases. I just want to make a question over here for all of you to understand as well. This data is from ELSO, which is basically only talking about a base population of about less than a billion people. That's the kind of target population that these patients are coming from. So India alone could be a huge factor were ECMO to have penetrate in any significant way over here. These are sort of the international summary data, and I'm just not going to go over that other than to highlight that the majority of the patients are neonatal respiratory, about 55%, and if you put the cardiac and the neonatal respiratory together, along with the kids who get eCPR in the neonatal period, that accounts to more than 2 out of every 3rd patient on ECMO. And so though we are here talking about critical care in pediatrics and in adults, it's somewhat a little sad to see that there is hardly any contingent of neonatal intensivists to try and be involved in providing or expanding their knowledge or experience on using this therapy in their arena. So maybe it may happen that it is the pediatric side of Indian medicine that will take the lead, not only for the pediatric patients, but also for the neonatal patients. I'm going to move forward over here. So neonatal ECMO started around here in these 2 centers, and this is the evidence. So these are sort of 3 trials. One of them, Gross et al., is the only randomized trial, but the other 2 by Bob Bartlett and Pearl Rook are adaptive trials, in which Bob Bartlett's was the classical play the winner. The patient gets randomized to one therapy. If the patient survives, the next patients do not get randomized, they get automatically placed in that same therapy. So what happened? The first patient got randomized to conventional therapy, that patient died, and then the subsequent patient went to the ECMO arm, and all subsequent 11 patients that went to the ECMO arm all survived, and that was the end of this trial. And with that trial and Pearl Rook's subsequently trial, which is also an adaptive trial, it became quite evident that in the United States, there was no equipoise left now to do a true randomized trial. And starting in 1988 and onwards, there was an explosion of neonatal ECMO, both with regards to the centers and with regards to the cases. And in fact, this had gone into the public arena where there were editorials and comments that people were withholding this life-saving therapy from sick newborns. However, the equipoise was maintained in the United Kingdom, and they went ahead and did a randomized trial, and they showed clearly that there was 41% survival in the patients randomized to the conventional arm, and with an intent to treat analysis, the kids who were randomized to ECMO, there was 68% survival, and the kids who were randomized and who actually did get ECMO, there was still 68%. So this study basically proved undoubtedly for neonatal respiratory failure that ECMO has a role to play, and now with that trial there was 1 extra survivor for every 3 ECMO patients irrespective of diagnosis. And this was just a summary data, so I'm just going to move forward from here. And this is data that I also showed yesterday quickly, but the number of neonatal respiratory cases are declining from a peak of about 1,500 to about 800 to 1,000. but the survival also has sort of more plateaued off, whereas earlier it was in the 80 or the high 80s, now it is somewhere in the high 60s. And this is probably a reflection of our better understanding of neonatal respiratory diseases, the therapies that we have to play with, and also we're getting patients who are far more moribund by the time we are considering ECMO. So these are going to be all factors that you all are going to have to think about when you're going to start. On the neonatal cardiac side, you can quite clearly see the number of cases are increasing and the outcomes are not as dramatic as for respiratory, where the survival is about 40%. With regards to the neonatal respiratory diseases, again you can see over here, the best diagnosis is meconium aspiration, where you have the best outcomes. Hyaline membrane disease, either primary or secondary in the late term or the term child, also has the best diagnosis, best outcomes. With regards to patients who have diaphragmatic hernia, these patients are far more complicated, and at the moment the best outcomes are 50%. Now this is again data which spans so many years. There are now centers who do CDH therapy, which includes ECMO, and center-specific outcomes are now in the tune of 80 to 90%. With regards to the neonatal cardiac, this is basically, the take-home message is very clear. It's basically a treatment for congenital defects. So majority of the patients who have congenital defects, either pre-operative for stabilization or majority post-operatively who can't be separated or have a subsequent crash after separation from the pump, land up on ECMO. And the survival over there is about 38% globally. And again, there's a lot of variation with regards to the defect diagnosis and the outcomes. So we need to be careful about that. Also, in the neonatal cardiac, though the numbers are extremely small, but there are viral myocarditis and cardiomyopathy patients where the outcomes are far more successful in the range of about 60%. So I'm just going to move forward from here because I need to touch on something which is far more important from the perspective of my talk. Okay, so the indications, it's not a therapy per se, but it's a support mechanism allowing the heart and the lung and the other tissues to heal while you're supporting them. So I talked about this. An ideal ECLS candidate should have an acute disease. It should have a reversible disease. It should be reversible. And there should be as few or none comorbid diseases. The minimal mechanical ventilation duration should be sort of developed and ascertained for your center. And we must make sure that this patient, you've exhausted your available best conventional managements. And if you were not to offer ECMO, the chances of this child to not survive are very high. So going on from there, so these are sort of the ways that you may sort of look at and try and model your own programs. So when we talk about neonatal, we need to look at neonatal respiratory, and we'll talk about neonatal cardiac separate. So in the neonatal respiratory patients, one thing that you need to think about is globally, is that patients are selected as candidates to receive ECLS on the basis that their risk of dying or having significant morbidities are greater than the risk associated with receiving ECMO. Now this is both for respiratory and cardiac. Okay. Now this is very important because in years gone by, people have done and moved the limits down with regards to gestational age and birth weight. And though sometimes it may only be a technical issue, but then in many issues, it's the prematurity that has a huge confounding factor to morbidities. So we need to be very careful about how we select the patient. Once we've selected the patient, then we have to start thinking about also qualifying criteria. But before we go further, so these could be some of the selection criteria that you may want to think about using. So a late term, a preterm, or a term baby, a birth rate of greater than 2,000 grams. Again, this is basically in relation to the technical components of having adequate size cannula placed for adequate cardiac support. Mechanical ventilation should be limited. The disease obviously should be reversible. No major intracranial hemorrhage. And again, this may not be an absolute, but this is something that I think in a startup programs, these should be sort of followed quite religiously. But subsequently, you may want to relax it once you have better experience. Obviously, if the child has a severe irreversible hypoxic brain injury or other injuries, uncontrolled coagulopathic or bleeding states can be quite challenging in a patient that you're going to try and support on ECMO. And as obvious, there could be a lethal malformation or congenital anomalies, and those may not be offered or supported on ECMO. So the contraindications to neonatal ECMO, some of the absolute ones would be a premature baby, a cardiac or a lung injury which is untreatable, severe intracranial hemorrhage, a severe hypoxic brain injury, other organ injuries which are irreversible, and obviously a lethal malformation. Some relative contraindications, once again, are in relation to birth weight, more so from a technical component. And I can just tell you, we have supported kids who are term or more mature, but who are SGA children quite successfully. So it can be only determined by you guys as a team while you're doing this. And again, the extent of mechanical ventilation. The others, in my sense, are actually going to be targets that are going to evolve in each of your centers as you practice. And that's why I say that most of these could be scratched out as your comfort zone and your experience evolves. Once you go from there, then there are the qualifying criteria. So once you've selected the patient, you don't want to put every patient on. You need to now see how sick they are before you're going to offer them ECMO. So these are some of the indices that people have used with regards to qualifying a patient for neonatal ECMO. And again, this is all sort of, can be provided. We don't need to go over in detail. So there are sort of, again, pretty severely hypoxemic kids, whether by AADO2 gradients or by oxygenation index, and so on. At this point in time, I think more and more centers in the Western world are not looking at any one of these criteria specifically, but the global clinical look of the patient, both with regards to respiratory function and cardiac function. Okay. And that's what this is sort of highlighting, is basically a relation of what the lung failure is and the pump failure is. So when we go forward and then we think about some of the diseases that we place kids on in the neonatal period for respiratory disease. And as you can see over here, most of these conditions are basically a maladaptive state. So that's the beauty of neonatal respiratory patients, So they come out, they're not adapting to newborn life, and basically the fetal to newborn transition has not happened due to these inherent conditions. And when that doesn't happen adequately, these kids begin to go down the tubes, and then despite all the other kinds of supports that you may try to alleviate their primary disease from, if you are unsuccessful, then ECMO certainly has a role to play. With regards to neonatal cardiac, I showed this slide. Neonatal cardiac is a group of patients which are sort of exploding in current years in the Western world. And what would be the indicators? There are no randomized trials, but it is widely used now for the cardiac surgery patients when you are unable to separate from cardiopulmonary bypass. Or the other predominant reason in neonatal cardiac ECMO is you have a low cardiac output state. So whether you have a low cardiac output state in relation to the issues around separation or cardiomyopathy, or myocarditis. Okay, so yeah. Okay, so those would be the main indications. So the primary reasons when cardiac neonatal ECMO is done is number one, as I said, is for the separation issues, and number two is for a low cardiac output state. So again, we need to remember that when we are placing these kids on, the myocardial injury must be reversible. We must ensure that the repair is adequate. And we'll have to talk a lot more about this, but that is a key component of doing successful ECMO. And we must optimize all of the forms of therapy. Okay. And with regards to the contraindications in neonatal cardiac ECMO, there are some relative contraindications like single ventricle and patients who have a shunt physiology. And these may be something that you may get comfortable over time, but certainly may not be the best patients to be placed on ECMO as an evolving center. I'm going to stop over there and I can take questions.
Thank you, Dr. Singh. The questions we'll take it at the end. Now, thank you very much for an excellent session. Now I call upon Dr. Sunil Puboni. He is a consultant in pediatric critical care and ECMO at University Hospitals of Leicester, UK. He will speak on pediatric ECMO for 15 minutes.